All right, morning everyone. We're going to try and start on time so we can get everyone to the ORs on time. So today we have a great talk that's going to be given by two of our fellows. Nicole Webb is our cardiac adult anesthesiology fellow, and Fisal Alamri is the cardiac surgery fellow who's focusing on aortic surgery. So this morning they're going to give us a talk and try and give us some insights into aortic arch surgery, some of the neurophysiology, the monitoring, and for everyone from general anesthesia is here, I think there'll be some interesting points and take-home messages for you as well. So without any delay, Dr. Webb, thanks.
So good morning, everyone. My name is Nicole Webb. I'd like to begin the discussion by just saying that I have no disclosures, either personal or financial, to disclose. The goals of today's lecture are to discuss some of the methods of cerebral protection, to review some of the cerebral physiology, especially associated with hypothermia, some of the ways that we can monitor the neurological status during these surgeries, and then to discuss some of the different cannulation and perfusion approaches. So to begin, let's review some basic neurophysiology. Here is the autoregulation curve, which we are all familiar with. It shows us the relationship between cerebral blood flow and mean arterial pressure. This is generally thought to be maintained by autoregulation between a mean arterial pressure at a low of 50 to 60 and a high of 150 to 160 millimeters of mercury, and is thought to be shifted to the right in those with chronic hypertension. Similarly, cerebral blood flow is proportional to the arterial CO2 between a PaCO2 of 20 to 80 millimeters of mercury. Our blood flow changes around 2 mils per 100 grams of brain tissue per minute per millimeter of mercury change in the PaCO2. So we know that the partial pressure of carbon dioxide in the blood it greatly influences our cerebral blood flow. And what's particularly crucial to this lecture is that the blood flow changes somewhere between 5 and 7% per degree change in temperature. It's also important to remember that 60% of our cerebral metabolism is dedicated to supporting neuronal electrical activity, and the other 40% is actually dedicated to maintaining cellular integrity. So while we worry about ischemic damage in all of the organs, the brain is particularly fragile because ischemic cellular injury is irreversible. And this occurs after cessation of blood of only 3 to 8 minutes time, and we presume that that's in a normal thermic brain. We should also keep in mind, on the other hand, that hyperperfusion or luxury perfusion can result in cerebral edema, and this can also be deleterious. So there are different kinds of ischemic injury. It can either be focal or global. When we talk about global injury, we talk about hypoxia or cessation of perfusion, the way that we would have in a circulatory arrest. Focal injury usually results because of an embolic, hemorrhagic, or an atherosclerotic stroke, and can also occur due to physical trauma. Ischemic injury begins when the cerebral blood flow is less than somewhere between 10 to 15 mils per 100 grams of brain per minute, and again, that's at normothermia. So how do we protect the brain? There are two major ways that have been validated, and those are hypothermia and reducing or eliminating the total cerebral ischemic time. And that's why we now have methods of cerebral perfusion. Other potential methods are pharmacologic means of reducing our cerebral metabolism, and we'll talk more about that throughout this. So what's the Q10 rule? So this just reiterates the knowledge already mentioned that metabolism decreases with decreasing temperature. The EEG is often, but not always, isoelectric at 30 degrees. And it should be noted that the temperature at which a patient is isoelectric varies widely. When we're at 15 degrees, the total cerebral metabolism is reduced somewhere around 84% from its baseline. So hypothermia can actually be used as a sole method of protection for ischemic times, generally thought to be of 30 minutes or less. And this is kind of the classic approach to surgeries that require a bloodless field. Selective cerebral perfusion has allowed varying degrees of hypothermia as an adjunct. So how do we do this? Cooling is done through a heat exchanger of a perfusion circuit with a temperature gradient of arterial to venous blood that generally doesn't exceed 10 degrees. And this is to prevent formation of gas emboli, and this is particularly important during the rewarming process. So what about the head? There are mostly animal studies when we talk about cooling the head itself. And some of the ways of doing that are either packing the head in ice or to use what's called a circulating water jacket. So when they looked at animal studies, they saw that packing the head with ice improved mortality and neurological recovery in animal models who had deep hypothermic circ arrest, but this was without antegrade cerebral perfusion. The reason why they think that is, of course, when you're under circulatory arrest, the brain can passively rewarm, and by cooling it, this is a means of kind of maintaining a cold brain and mitigating that rewarming. This has never really been compared in a rigorous study against antegrade cerebral perfusion, and some evidence suggests that head cooling during rewarming should not be performed and that might actually have some negative effects. So again, with antegrade cerebral perfusion, there may be no extra advantage to cooling the head. There's some theoretical disadvantages of packing the head, and those include retinal ischemia, thermal injury, pressure injury, and that it might interfere with EEG and cerebral saturation monitors. However, there are actually no case reports of any of these negative effects. So what is this circulating water jacket? On the right here, you can see what it looks like, and it would be nice if it was just all nicely tucked in like that. Really, it's kind of an awkward thing to wrap around the person's head, and usually they're just kind of covered with a little endotracheal tube and an echo probe sticking out, so it is a bit cumbersome. There was only really one study by Lighthall in 2000, and he compared the cooling characteristics of packing with ice versus a circulating water jacket, but not on humans. He basically just had a flask of liquid and then one of these circulating water jackets around it compared to an ice pack. Overall, he found that the cooling jacket produced a more rapid cooling, both at the surface and in the center of the flask, but no clinical trials have validated this. Overall, there's no convincing evidence that head cooling improves neurologic outcomes. So profound hypothermia is enough to induce electrocerebral silence in about 80% of patients and provides protection for 30 minutes of hypothermic circ arrest. Deep hypothermia falls in the middle range of the temperature electrocerebral silence curve, so any change in temperature is directly proportional to a change in the likelihood of induction of ECS, or electrocerebral silence. This is thought to be sufficient for about 20 to 30 minutes of hypothermic circ. Alone, studies have shown that there's no diminished cognitive function. The stroke rate is about 5%, and a hypoperfusion stroke rate of about 1.8%. Moderate hypothermia will allow for 10 to 20 minutes of hypothermic circ arrest, and above 28 degrees, almost no electrocerebral silence is induced. But again, this is very variable between patients. So why don't we just cool everyone right down and make sure that we're protecting the brain? Well, hypothermia is not without its risks. Shivering, of course, increases our overall metabolic demand. It can increase infection rates. It alters the pharmacodynamics of all of our drugs. Certainly, it increases coagulopathy, bleeding, and the potential for transfusion-related complications. It causes platelet dysfunction, and because of all of this, there's a prolonged bypass time, which dilutes our coagulation factors. The increased bypass time is also necessary for rewarming and for hemostasis after these surgeries. And there is some evidence in the literature that there is a potential increased risk of reoperation. So this is kind of a classic slide in the anesthetic literature, and certainly our residents will get grilled on all of the effects of these medications in terms of how they affect cerebral metabolic rate and cerebral blood flow, which are not necessarily directed in the same way. So although anesthetic agents do decrease the total metabolic rate and can induce electrical silence, they cannot alter the cellular basal metabolic rate. and none of these have been proven to protect against global ischemia. So some centers advocate the use of other adjuncts. There's some thought that lidocaine might decrease the cerebral metabolic oxygen consumption rate, that magnesium can somehow alter NMDA-activated calcium channels and reduce vasospasm. And so they like to give 100 milligrams of lidocaine and 2 grams of magnesium during the cooling. But this has not been shown to significantly or consistently improve neurologic outcome after the first postoperative days. Steroids may actually decrease pro-inflammatory response and prevent brain damage, but the main thing is that these can cause hyperglycemia, and hyperglycemia can be very deleterious to the brain function. So there's a lot of conflicting studies regarding the benefit of steroids, and the overall evidence is inconclusive. So then we come back to our general considerations, which all make a lot of sense and are things that we do in anesthesia every day, especially for neurosurgery. Certainly want to avoid hypoxemia, maintain an adequate hematocrit, avoid hypothermia, which is going to be one of the most deleterious factors in terms of brain function and damage. Avoid hyperglycemia, as mentioned. Our goal is to maintain normal carbia, and we definitely want to maintain a cerebral perfusion pressure that's going to keep our brain in an autoregulation curve. We might also consider muscle relaxation just to avoid the overall metabolic demands of shivering. So what monitors are indicated in aortic arch surgery? We want to take close control of our temperature monitors. We certainly are looking at arterial blood pressure monitoring and blood gas monitoring, and then neuromonitoring. So temperature monitoring. This is usually done through the inflow and outflow lines of the perfusion circuit. It is also measured either by a bladder or rectal probe, nasopharyngeal, esophageal, or a tympanic probe. So the bladder temperature changes are usually delayed compared to a nasopharyngeal or a temperature probe. So if deep hypothermic circ arrest without cerebral perfusion is being performed, the nasopharyngeal or tympanic probe most closely approximates the brain temperature. If you're using antegrade cerebral perfusion, then the bladder or the rectal temperature can be used to initiate hypothermic circ arrest. Again, during rewarming, there should be less than an 8 to 10 degree arteriovenous difference up until 30 degrees, and then some advocate that there should be less than a 4-degree difference above 30 degrees. Dr. Alamri will talk a little bit more about cooling rates later on in this talk. So in terms of arterial monitoring, the placement of our arterial cannula will depend a little bit on the cerebral perfusion plan and a little on surgeon preference. But in general, you're going to need one arterial line prior to induction and another arterial line for monitoring during antegrade cerebral perfusion and hypothermic circ arrest. We know that in axillary cannulation with antegrade cerebral perfusion, this will distort the reading of the arterial line of the art line that's on the same side. So you can have many different combinations. And then in terms of blood gas analysis, this again varies by center, and unfortunately there is a lot of evidence in the literature that is conflicting. So the pH stat, or temperature corrected, is generally thought to be measured during cooling, and the alpha stat, or non-temperature corrected blood gases, are measured during rewarming and reperfusion. And there is some evidence that the alpha stat patients had reduced neurological impairment post. So neuromonitoring. Our main ways of monitoring are cerebral oximetry, or NIRS, which is near infrared spectroscopy, and then EEG or processed EEG, and we'll talk a little bit more about that. Some of the adjuncts can include evoked potentials, either motor or somatosensory, although that is not really the focus of the talk and relates a little bit more to spinal perfusion. And then other adjuncts can include Doppler ultrasound or looking at cerebral vascular flow, but this is not routinely performed and we're not going to go into it too much today. So cerebral oximetry. We're actually measuring the regional cerebral saturation, and there's a lot of variability in patients' baseline. During right axillary cannulation, the right cerebral sat should be monitored throughout for malperfusion of the right cerebral hemisphere. Selective antegrade cerebral perfusion should be titrated to maintain SAT above 60 degrees, and we have to take this with a little bit of a grain of salt because we know that there is a lot of variation between patients, and definitely should be maintained within a 20% of the patient's baseline. So the other thing to consider is that if we have a patient who starts with a very low baseline and we aim to bring them up to 60%, we might actually be causing harm by providing kind of a hyperperfusion or luxury perfusion, and that this can result in cerebral edema. So this is just a little bit of the technology. What we're using for cerebral oximetry now is called the INVO system. It's important to remember that this monitor only detects regional changes in saturation. So any kind of focal ischemia that's out of range of the monitor will not necessarily be detected. And it's important to know that we have also available the pediatric strips, but the pediatric strips and the adult strips are not interchangeable because the algorithms are dependent on the size. And so if you put a strip on a missized person, it's not going to be accurate. So the other thing to think about is that these reported numbers are taken from the venous pool of blood, which is 70 to 80% of the blood in the brain. So these numbers don't necessarily represent arterial or tissue saturation. And then there is some conflict in the literature as well about whether cerebral oximetry or NIRS correlates well or does not correlate well with jugular venous oxygen saturations. So again, it's up to your own interpretation. So what are the limitations of cerebral oximetry? There are some confounding factors in an abnormal brain. You're looking at a very small area. Desaturation and what that means hasn't really been defined, and it's non-specific. So we don't know if this represents systemic or regional ischemia, and we don't know, it doesn't give us any information about if it's a problem with consumption or oxygen delivery. Desaturation is non-predictive in terms of neurological outcomes, and it's less sensitive and less specific than an EEG. So this is the standard EEG system that I'm not going to talk too much about, but classically it was the primary modality used during aortic arch surgery, and you can see by the number of probes that it's rather cumbersome technology to apply. It's mostly used during cooling to ensure reduction of activity or isoelectric or silence. So the baseline EEG is generally performed after induction of anesthesia, but prior to cooling. And the main thing that they want to identify is whether there's any asymmetry or abnormality. During cooling, the EEG amplitude decreases, and so the sensitivity with which you're monitoring should be increased. In some centers, interestingly, the anesthetic is actually discontinued during cooling to account for the effect of the anesthetic. So it's discontinued at either 28 or 38 degrees. The anesthesiologist involved in cases should be familiar with some of the waveforms. So in A, we see that this is an awake patient, and they have these beta and gamma oscillations, compared to waveform D, which shows slow and alpha oscillations that show unconsciousness at a surgical level of anesthesia. And then F shows unconsciousness with burst suppression, and G shows isoelectricity. So I'm not going to go too much into all of these changes. As mentioned, these EEG changes can either be lateralized, generalized, or periodic electrical discharges, or they can be these kind of synchronous increases in EEG amplitude, but against a background of continuous activity. Burst suppression occurs somewhere between 15.7 and 33 degrees, so that gives us some idea that the variability between patients is quite wide. And then during rewarming, this process is reversed, but the patterns are less predictable than during cooling. In general, we think that burst suppression appears at around 21 degrees, and a continuous EEG pattern generally reappears at 30 degrees. So there is some evidence in the literature that you can actually use the EEG to guide cooling, and that this may allow some excessive depth or duration of hypothermia, but I have not found in the literature that this has been adopted as a protocol in many centers. So I also mentioned processed EEG, which is what we're using now, and I think most of us are familiar with something called the BIS, or the bispectral analysis. So these are actually marketed as a depth of anesthesia monitor, not really as kind of a simple EEG. The algorithms for these are proprietary, and they say that a BIS between 40 and 60 are numbers where you're unlikely to have anesthetic awareness. But what that means in terms of an actual EEG pattern is not completely clear. So again, it's mentioning the bispectral analysis. There are many different monitors available, but there are many limitations as well. So depending on whether you have muscular activity or not, this can confound your results. There's a lot of interference from different machines in the operating room, and you can have different changes in cerebral metabolism that will also affect your process EEG. Seizures can also affect this, and different medications will have different BIS patterns that will render them, I guess, unreliable according to the manufacturer. And these include ketamine, nitrous oxide, potentially etomidate, and even ephedrine. So this is the SED line, which is what we are now using here. So between a cerebral oximetry and a SED line, hopefully our patients have generous foreheads to put all of these stickers on, because they do take up a lot of space. This SED line uses 4 EEG channels. Like the BIS, it's marketed to estimate anesthetic depths. It's measured on a dimensionless scale of somewhere between 0 to 100 of what they call the patient state index, or the PSI. A PSI of 25 to 50 is advertised as an optimal level of depth during a general anesthetic. So regardless of the EEG monitor being used, it's important to remember that EEG silence only represents suppression of metabolism related to neuronal activity, but that metabolism related to cellular integrity is still ongoing and cannot be reliably measured. So in summary, cerebral saturation should be closely monitored, and any change from 20% of the baseline should be immediately addressed. Some centers advocate discontinuing the anesthetic at 30 degrees to avoid confounders. And in general, the EEG should be isoelectric prior to initiation of deep hypothermic circuit rest. At this time, there's insufficient data regarding EEG-guided management of moderate hypothermic circuit rest. And the processed EEG is a surrogate monitor for EEG and has not really been validated for arch surgery. There are some unanswered questions. We don't know what neurologic outcomes in patients with continued anesthetic versus no anesthetic at 30 degrees would be. And we don't know if neurologic outcomes during moderate hypothermic circuit rest correlate with EEG or processed EEG patterns. And although there is some evidence that EEG-guided interventions or guided initiation of circuit rest might be possible, we still need, I think, more data before we can say that reliably. So now I'll switch over to Fisal, who will talk to you a little bit about cannulation and perfusion.
Good morning, everybody. So my name is Fisal Alamri. I'm Aortic Fellow in Cardiac Surgery. Actually, when I start to talk about this topic, I choose to talk more about the perfusion strategy and how we can safely protect the brain during and what modality we have to protect the brain during arch or hemi-arch procedure. I'm going to talk also about a little bit about method of cannulation technique, and then we're going to go over some troubleshooting stuff too. So actually, when you talk about aortic surgery, the aim is to work on surgically less blood field, and that's only can happen if we interrupt or stop the cardiopulmonary bypass to the brain. To do that safely, we have 3 methods on bypass. So the first one is deep hypothermic circulatory arrest. This is the standard of care for long time, and still be until now. It first discovered by Webb in 1975. He's the one who introduced this to aortic surgery. It was there since like 50s in pediatric by Kirkland and its group. They use it to close ASD, but they have VFib arrest problem at that time. But they continue to use it in pediatric, but Webb, he's the first one to introduce it for aortic surgery. So at the beginning, when the literature talk about deep hypothermic circulatory arrest, they didn't talk exactly about the similar outcome between each other. Recently, after we have been doing a lot of complex aortic surgery and arch surgery, we see a lot of complication, common complication between this patient. So all the literature I'm going to present, they're going to talk about mainly 3 outcomes: the mortality, the permanent postoperative neurological dysfunction, which is referred as PND, and the transient neurological dysfunction. So to understand those, I'm going to start with definition for each one. So the PND is defined as persistent focal or global neurological dysfunction with correlation on CT scan and MRI. So you have a focal like stroke or a global, and you can see that in CT scan when you do it. The transient, the TND, defined as occurrence of post-operative, timely limited confusion, transient motor weakness, or seizure or agitation without any evidence in the CT or MRI. And it should be self-limited or reversible at the time of hospital discharge. So Nicole talked about the hypothermia and how hypothermia can protect the brain. So for each 6 to 7% per 1 degree decrease in the temperature, the brain will decrease its metabolism 6 to 7%. But that has a limitation. I mean, it's not all the way to become 0, because also Nicole showed that 85% at 15 degree, they will still, 15%, they will still, there is some sort of metabolic activity. So usually this is started at 33.5 degree and continue below like 19. If you continue below 19, 85 of your patient, they're going to have EEG silence. Also of note that moderate hypothermic circulatory arrest, when you applied like 28 degree, that's actually decrease your brain metabolism more than 50%. And this is very important because we're going to present this shortly. So when they apply the deep hypothermic circulatory arrest, because they don't define all what we said about PND and TND, so they thought they have safety about deep hypothermic circulatory arrest up to 1 hour without any problem. But recently, when we do more complex procedure and we define those factors, we found it's not actually. So it's actually more than 25 minutes. If you go only with deep hypothermic circulatory arrest, the TND and fine motor deficit, and there is significant prolonged hospital stay. Fisher also did an experimental study after 30 minutes of deep hypothermic circulatory arrest at 15 degree, which is almost, it's profound hypothermia. The oxygen saturation in the frontal brain is actually decreased by 60%, which is it's not safe for serious adverse outcome. Another studies also came after, showed that neurological complication occur more frequently when your deep hypothermic circulatory arrest become more than 40%, either transient or permanent. So all of this let the people think about other modality to actually, if they have more complex procedure and they wanted more time to do their work or anastomosis, so they thought about other modality, and we're going to talk about them. But it's very important to talk about a factor that's very important during when you use the deep hypothermic circulatory arrest. The first one is your target, so cooling target. So what's temperature I should go if I use deep hypothermic circulatory arrest? So a lot of study done, and this also a table showed by Nicole, similar to this one, showed that at normal temperature, of course, the brain will be 100% active, so 5 minutes only you have before you see a complication. At 30 or 28, you're going to lose like 50% of your cerebral metabolism, and you're going to have 10 minutes of deep hypothermic circulatory arrest. I'm talking here about the brain. At moderate, the spine, actually, you can go up to 40 to 45 minutes. 25 degree, it goes like you have 15 minutes. 20 is 20, 15 like 30, and 10, which is ultra profound, is 45. This is a very important slide for the resident too for exam. And also Nicole talked about the cerebral metabolism ratio and oxygen consumption, and this is the formula how to calculate them. The second very important topic when you talk about deep hypothermic circulatory arrest is cooling duration. So let's say you want to go to 18 degree. If you go like in 20 minutes, which is very rare, very impossible, but sometimes let's say you did it, it's not safe to stop it. Because most of the studies showed at least you need 30 minutes to stay, to cool. Even if you reach 18 degree at 20, you have to stay at least 10 minutes before you stop your cardiopulmonary bypass. But the safest and the better, usually between 45 to 60 minutes. And that's why, because a lot of studies show that EEG silence occur in more than 95% when you cool between those 45 to 60 degree. And this is very important, especially when you have patients with a lot of comorbidities, include peripheral vascular disease, because they don't have homogeneous cooling to the brain, also diabetes, hypertension, and all CVA. The third one is the perfusion pressure, and the pH or alpha stat, perfusion flow, and hematocrit. Those all has to be also monitored during deep hypothermic circulatory arrest. So due to that, all of study and also the result from deep hypothermic circulatory arrest, the surgeon tend to do faster surgery and fast anastomosis, and that put a lot of stress. So a lot of surgeons think about why we don't prolong this safely and do better job and less stressful field. So the second modality they come up with is deep hypothermic circulatory arrest with retrograde cerebral perfusion. The first one thought about this thought is Mills, and this done in 80. He actually didn't use it for aortic surgery. He used it for an air bubble in the aortic line, which went to the brain. So he actually took the art line from the aorta and he put it to the SVC, and he flushed backward the air from the brain. It took him UDAP like 10 years to introduce this to aortic surgery. Usually, typically, we flow this between 1 to 500 per minute, and we keep the CVB around 15 to 25. So the reason why they introduced this is for 3 reasons. First, they want to support the brain with more metabolic support, like nutrient, and also they want to flush the brain from any debris, embolic stuff, atheroma, or any air, and also maintain cerebral hypoperfusion. And then a lot of study done to show if this is actually working or not. I'm going to talk about the technique here. It's very simple. So this is the anormal circuit. So the arterial line comes, you have to wire your arterial line. This is going to your central cannulation, whatever is like aortic or axillary or whatever. And this is your venous. You have to do bicaval cannulation, one to the SVC, one to the IVC. And then the only thing you add is a shunt between the aorta and the SVC. You clamp this shunt during cardiopulmonary bypass and the cooling process. And once you stop your pump, you can declamp that and clamp the venous line here. And you start your retrograde through the SVC. So, and then a lot of study done for retrograde to prove that they have the 3 benefit, which is the nutrient and the flush back and also the hypothermia. So a group from New York did an experimental study on pigs. They showed that there is actually very minimal support or nutrient going to the brain during retrograde. And that they did it by they did fluorescent microspheres trapped in the brain, and they measure it. it was very low. It's like 0.02 ml per minute per every 100 gram of brain parenchyma. And also what's shocking is they found that 13% only comes back through the aortic. So most of the retrograde actually goes to the IVC through venous connection between SVC and IVC. So the nutrients is not there in this experiment, and also the flashback is not enough, like only 13%. The only proof benefit from this is hypothermia to the brain. So because of also this study, another group think about something else they can do to prove or improve the perfusion. The third modality is selective cerebral perfusion using antegrade cerebral perfusion. The first group, they did it actually for carotid aneurysm. It's from Houston, and they did it on normothermic. They didn't use deep hypothermic. 1 year later, DeBakey also used it for a mycotic aneurysm in the ascending and proximal arch, but he did cannulate directly both carotid and right femoral. And this was abundant because the stroke rate was high, because as a lot of manipulation to this head vessel cause a lot of stroke. So it took them some time until the Gulmit and from Europe and Kawase from Japan find the principle, and they put the antegrade cerebral perfusion with deep hypothermic circulatory arrest for aortic surgery. So when you consider antegrade cerebral perfusion, you have to think about the target cerebral blood flow you want to flow, and the blood pressure, the perfusion pressure, and the hematocrit or the hemodilution. All of this is very important when you consider antegrade cerebral perfusion, because when you have any problem with saturation, as we're going to see, you have to troubleshoot all of them. So the first study I'm going to show here, Jason, he reported their experimental result. They found that the minimal flow that we can do antegrade cerebral perfusion is 6 ml per kg per minute. And this is the minimal safest flow. But most centers now, after a lot of study, adopt that the flow that they go with is between 8 to 12 ml per kg per minute, with a perfusion pressure of 40 to 60, and the temperature between deep, like 23, or moderate to 28. It's very important, the flow, because if you flow too much, you're going to cause brain edema, and you're going to cause, again, desatting. Or if you decrease your flow, you're going to also cause global ischemia. This is a very busy slide, but it showed the best evidence paper. I just want you to look at the beginning, at the first of each one. So if we talk about antegrade cerebral perfusion with moderate hypothermic circulatory arrest between 28 to 32, this study include 1,000 people. And actually, if you look, it is very nice that you see that the circulatory arrest or with antegrade cerebral perfusion, the ischemic time was between 20 minutes and 50 minutes, which is beyond that 30 minutes that we talk about deep hypothermic circulatory arrest. If you see, the result is 5% for mortality, 3% for BND, and 4% for TND, which is very, very good. And I mean, those numbers, because this is what you're looking for as a good result in aortic surgery. If we look for deep hypothermic circulatory arrest, when you use antegrade cerebral perfusion, if you look like also a long ischemic time, it still have the same also good result. If you compare by cannulation, by antegrade cannulation, which is left carotid and innominate, with the unilateral antegrade, which is the innominate usually, they have the same ischemic time, and the result also is the same, no significant difference between both of them. Retrograde have a good result, but it's still, the ischemic time is less than what we're seeing in antegrade. The deep hypothermic circulatory arrest also a little bit lower in the term of result than others, but their ischemic time is even less and less. So So the first question always comes to us, antegrade versus retrograde with deep hypothermic circulatory arrest. Does that matter which one you're going to use? So there is a study done in Leipzig Center. They found 6 years. They have like 600 patients. They found statistically different between the circulatory arrest between the two groups. The antegrade cerebral perfusion tend to have more ischemic, more ischemic or circulatory arrest time than the retrograde, and those also more than deep hypothermic circulatory arrest. Usually like between 22, bilateral 23, 18 to 15. So, and that's reasonable because most of the surgeon, when they tend to have, they anticipate longer deep hypothermic or circulatory arrest, they usually go with antegrade cerebral perfusion, so they can, take time to operate. If they think that the circulatory arrest will be short, they use like retrograde or deep hypothermic circulatory arrest. So they conclude in their study that any form of antegrade, whether with deep hypothermic or retro, is actually identified as a protective against any development of BND. So antegrade cerebral perfusion is better than retro, better than deep hypothermic alone. And that's with odds ratio of 0.4, which is very significant. The mortality was the same, no change. And also they found that type A dissection and myocardial infarction and total arch with elephant trunk or duration of cardiopulmonary bypass, all of these are independent predictor of early mortality in aortic surgery. Another group from University of Pennsylvania, they compare two different group, which is retrograde with deep and moderate with antegrade. They found there is no difference between the outcome in terms of BND or any TND or mortality. Another group from Duke University, they have 400 patients. Also, they found the mortality 30 days in hospital was the similar between antegrade and retrograde, and also the 30 days morbidity was similar. So also a meta-analysis about like they have 2,000 patients, they didn't find any difference between retro and antegrade. Okay, the next question is always asked, when you use antegrade cerebral perfusion, do you gonna use unilateral or bilateral perfusion? Again, usually the surgeon tend to use bilateral in more complex procedure and carotid stenosis or previous stroke patient, or if they have a CT confirmed that there is a incomplete circular fills or any posterior communication, also a problem. A study from Duke University showed that, a meta-analysis was done on this. 5,000 patients. They compare like 2,000 of ACP with unilateral and bilateral 3,000. They found no difference in 30-day mortality between the two groups. Only 2 studies showed that there is difference, but both they are, not good because they have very low patient, like 65, and the other, and they don't have propensity score matching. The second study was only showed that bilateral better in quality of life, but no change in the mortality or neurological complication. The biggest, report from Germany, which showed our type A aortic dissection in circulation was published. 1,000 patients, they compare both. They conclude that there is no difference in performing cerebral protection with bilateral or unilateral. Vienna group also confirmed that in their study. They actually did Kaplan-Meier analysis. Even for long-term survival, there is no difference at 5 years survival too. 2 studies done actually in prolonging like more than 40 minutes. One from Bern University in Switzerland. They have like 120 patients. They showed slightly maybe bilateral ACP may be favorable in case of prolonged circulatory arrest more than 50 minutes. The other question is, do we go moderate or deep hypothermic circulatory arrest? People now tend to use moderate more than before, and due to a lot of study also come out showing that moderate actually is very reliable and also safe to use in any complex aortic surgery. So study in animals showed that cerebral oxygen consumption. So there is some belief in surgeon. They think that at 28, this is the best, decrease in the metabolic rate you're going to have. After that, you're going to have only slightly decrease in the metabolic rate, and they don't believe that it goes like to 15% or something. They say no, they never go to that low, which is contradict the safety effect of the deep hypothermic circulatory arrest. But they also state that profound hypothermia that they do, they impair autoregulation of the cerebrum, the cerebral parenchyma, and also can cause vasoconstriction, and those both can decrease the flow to the brain during antegrade cerebral perfusion. So they thought maybe moderate, you're gonna keep the autoregulation, and the vessel will be not vasoconstricted, so you can deliver more antegrade and more neutral to the brain. Bleeding, also, they think it's less with moderate, and that's true. And that's usually the major effect of bleeding. It's not the hypothermia. I think it's the long bypass, because there is 2 studies done on this and showed that longer bypass is actually can cause you more coagulopathy than hypothermia. But of course, when you go deeper, you're gonna use more longer cardiopulmonary bypass time. So a study done on 300 patients, there is no difference between the mortality or morbidity between deep and moderate deep hypothermic circulatory arrest. And the results showed that moderate, actually lower body circulatory arrest, can be safely performed for aortic arch repair. And they actually tend to decrease the inflammatory response when you use moderate hypothermic. Another study done on profound versus moderate hypothermic circulatory arrest with antegrade in aortic dissection. This is a very good paper from Toronto. Algarni showed that moderate hypothermia was independently associated with lower risk of mortality and adverse cardiac and cerebrovascular event. They have a composite outcome which include mortality, low cardiac output, and stroke. They found it is more common with antegrade cerebral perfusion and deep hypothermic circulatory arrest, with very significant p-value and also, the difference between the two. They found also the cardiopulmonary bypass time and blood transfusion is more higher in those group than the moderate. And they actually conclude that the profound hypothermia was independent predictor of composite outcome by multivariable analysis with odd ratio of like 7.6. Another also group showed that using antegrade selective with moderate or mild for arch replacement, they actually comment that ACP make deep hypothermic is non-essential for aortic arch replacement. And the results suggest is that moderate can be safely applied to complex aortic surgery, even in some group of up to 90 minutes. Also, another group from Emory University showed there is no difference between the two groups, and actually there was no significant difference in stroke or BND or TND or even renal dialysis. In hemi-arch, also they showed also there is no difference between moderate or deep with antegrade cerebral perfusion. It doesn't matter also if you use it as an elective or urgent case. But they found in their also study that patient with moderate versus deep had a significant lower rate of P in D again, and that's have a p-value of 0.01. So cannulation technique, I'm just going to stop here about the perfusion study. I'm just going to try to find like maybe two pathology here There is a lot of pathology you can discuss about cannulation technique, but I'm going to talk about like if we have a simple one like ascending aneurysm with 3 vessels, of course. So what modality, what cannulation we can apply, what strategy we can use in this case. So if you have ascending aneurysm, in aortic surgery, everything is planning. It is very crucial in aortic surgery, so you have to take a detailed history, examination, including all pulses, and a CT scan is very crucial too, to see your anatomy, you understand, and also anticipate any problem you're going to face and troubleshoot them during the procedure. So most of the surgeon of aortic surgeon, they come to the room and they know what they're going to do. Very rarely they change, but like 10 to 20% they change their strategy into during the procedure, but usually they came in with already planned and perfusion and also temperature in mind. So if we talk about this, there is, if you have ascending aneurysm, there is two, you can do here. If you have a clamp site between the innominate and the ascending aorta, that means you have to have a normal tissue, a normal diameter aorta between both of them. Then you can just clamp. You don't have to do any deep hypothermic, just cardiopulmonary bypass, and then you have to replace the ascending under cross clamp. If you're gonna get rid of the cross clamp, then you have to do protect the brain with like some sort of deep or moderate hypothermic circulatory arrest with antegrade or retro. In this diagram, you show that all the aneurysm goes all the way to the innominate. So actually, there is no cross clamp site to do. So in this case, you have to use one of the modalities we use. This is a hemiarch. So if this is aneurysm, you look to the CT and you think that's, yeah, it's reasonable. Usually it takes between 10 to 20 minutes anastomosis. Then I can do this with a lot of, modality. Like I can do axillary cannulation, moderate hypothermia, and then just go stop the pump and then replace the ascending aorta. Or I can do like femoral cannulation, deep hypothermic circulatory arrest, and then stop the pump, take this off and do it. Or I can do it with also by carotid or by carotid cannulation through the aorta, through the carotid by using balloon inflatable cannulation. So the strategy, there is a lot, but you have to keep in mind that if you get in trouble, what are you going to do? If you use like deep hypothermic circulatory arrest with retrograde, through the femoral, if you dissect the, accidentally dissect the arch, what are you going to do now? What option are you going to do? So you have to keep that in mind. So that's why a lot of people now, they change actually to antegrade cerebral perfusion. And here we usually, with Dr. Moon, for this disease, we have two options. We like two options here. The first option, you can do axillary cannulation, and then you go moderate hypothermic circulatory arrest, 28, and then once you...
There are 10 minutes remaining in this video conference session.
And then stop the pump, clamp the base of the innominate, and then do your anastomosis. The other very new technique, which is, but this has two incision and take longer time. The other two technique, you can actually cannulate the aneurysm and cool down to 28, wire arterial graft, arterial line, and this is in every aortic surgery. You have to wire your arterial line. And then you can introduce innominate cannulation. We use it like, you can use like a graft, but we use here cylindrical technique as a femoral line, as you insert femoral line. And we insert like 14 or 12 French sheath of cannula inside that innominate, and then you can start your antegrade cerebral perfusion. So this diagram showed actually that if you cannulate the axillary and then you stop the pump, you close the base of the innominate and you start your antegrade cerebral perfusion. During that, you can actually start sewing your distal part. If you use innominate, We use better if you have side branch, so you can put your cannula inside there and then start antegrade perfusion. So one of the problem you can face with this technique, sometimes you're going to have a low saturation. So let's say the anesthesia, say your brain status goes down. And usually it's on the left side more than the right side. So how are we going to troubleshoot this problem? Anybody has? So you have to think about your connection. That's a simple thing. So make sure that everything is in place, your outline is in place, and all the numbers you are reading is actually true. If you do that and you're certain it's true, and as I said, usually it's in the left side the problem, the desatting done more than the right, then you have to think about your cannula. You have to ask your perfusionist, okay, how's your, do you have any problem with the pressure? I said, yeah, I'm flowing 500 with a pressure of 300. So there is a problem then. So you might maybe dissect the axillary artery. So then you have to, change your modality of cannulation. But if he said, no, everything is good, I'm 500 and everything is okay, and the pressure is good, so what are you going to do next? At this time, you make sure that you're not anemic, your hematocrit is fine, and everything is okay. If everything is okay, then it's your first thing to think about is the flow. So what's your flow is 500. Okay, can you go to 1 liter? It goes to 1 liter? Yes, everything is good now. Then you stop. That's good. Then you continue your sewing. If you still no, same thing, no change. Okay, you can go to 1.5 and let's see. You go to 1.5? No, it's not good. Then you have to think now about perfusion problem. So you can increase your perfusion pressure by clamping the left carotid, base of left carotid, so try to increase the perfusion to the brain. If you do that, usually at that time you're going to have a nice sat between both of them. No, if he said no, still there is a problem, then the last thing you have to think about is adding another cannula, which you can use like balloon inflatable cannula gantry, take it from your outline or the pleat side, and put it to the left carotid and flow bilaterally this time. If you still have problem, then you have to think about venous obstruction and brain edema, and you have to ask your anesthesia about if the brain is actually edematous or anything like that. The other also pathology is aortic arch aneurysm. And if you replace the arch, the crucial about planning is very important, because you have to come to the operating room, know your cannulation, your strategy, everything, and also your sequence of sewing the sequence of sewing the graft. Let's say somebody say, okay, I will start proximally, and then I will do the head vessels, and then I will do distally. The other one said, no, I will start with the head vessels, and then distally, and then proximally. Is there any difference? Yes, there is a difference. Why? If you use this type of graft, which is usually we use Cena graft, they have this extra graft here.